shift gears down a little bit. We'll talk about endobronchial ultrasound.
Okay, well, come to California, home of Apple, and your Macintosh doesn't work. Go figure. I have nothing to disclose apart from a malfunctioning Macintosh. Next slide, please. So I think when we talk about EBUS, we're all mostly referring to the linear EBUS, but to be complete, I want to just briefly touch on a radial probe EBUS. There's two types of probes, the radial and the linear one. Next slide. There are two miniature probes. There's the miniature one, then what's something that they call the ultraminiature one. The miniature one is a 2.5 millimeter diameter probe that goes through a very small flexible sheath that has a little balloon on the bottom of it and goes through a therapeutic bronchoscope. Next. The ultra mini probe goes through a sheath as well, but there's no balloon on it. Now the ultra mini probe is the one that we use for biopsying these peripheral lung lesions when we're doing navigational bronchoscopy, for instance. Next. This is what the miniature probe looks like. You can see the sheath that it's in here. This is the probe itself. Next. And then you couple the probe to this device that links it to the ultrasound processor, and this actually rotates the probe. Next. So this is what you see when you use the miniature, the ultra-miniature probe. This is a typical appearance of a lung cancer, fairly homogeneous. You'll see a continuous ring of tissue around here. That's the interface between the lung cancer itself and the compressed surrounding lung tissue. Next. Conversely, this is what you see in somebody who might have consolidated process such as a pneumonia. You see all these little linear hyperechoic things which are actually small air bronchograms, and you're not seeing this sort of homogeneous area here with a continuous interface around it. Next. The miniature probe is used mainly for evaluating larger airways, and it has been shown to be more sensitive than CT scan in terms of predicting tracheal and bronchial invasion by lung cancers. There are 6 separate layers described. Really, for all intents and purposes, there's only 3. There's the mucosa, which is 1. This first hypoechoic area, which is the submucosa and bronchial musculature. And then this second hypoechoic area here, 4, which is the cartilage itself. Next. This is a brief video here of a patient of mine that we just operated on, actually. He was a 31-year-old kid, treated for 2 years for asthma and was found to have an adenoid cystic carcinoma. By biopsy, it began 2 centimeters distal to the carina. We did a miniature radial EBUS on him. And you can see here the normal rings here. And just as you go distally, you're starting to see a little bit of loss of the normal structure. And this represents the tumor. Next. Gross specimen, you can see correlates with what we saw in the ultrasound. Next. And here in cross-section. I will tell you that this patient, we believed, had at least 2 centimeters of normal tissue between the carina and where the tumor began, but being adenoid cystic, it was actually 5 millimeters away from the carina. So the radial ultrasound was unable to help us determine that small amount of submucosal invasion. Next. So this is where I want to really emphasize most of my talk. Next. So this is the ultrasound that we're most familiar with. Could I have just a show of hands as to who routinely performs linear EBUS in their practice? So I'd say about half or so, maybe a little over. That's great. So as you know, this is a 6 millimeter diameter scope that has a curvilinear ultrasound array at the bottom of it. And then there's this balloon that we place over the probe, fill it with saline to increase the acoustic coupling between the probe and the wall of the bronchus or trachea. And then there's a working port here that comes out at about a 30-degree angle. There's a sheath, which needs to come out first, and then there's a needle that comes out through that sheath. It's a 22-gauge needle, about 2 centimeters long. You can get 4 centimeters out of it, though. Next. And the nodes that you get that are accessible to EBUS are certainly those next that are accessible by mediastinoscopy. Next, please. But has the added advantage next of being able to biopsy the level 10 and level 11 regions. Next. Obviously, you cannot reach, most of the time at least, you cannot reach the level 5 and level 6 nodes or the 3A nodes. 3P you probably can. Next, please. Next. And again. So this is a brief video. How are we doing on time? Not too bad. Of how I perform endobronchial ultrasound. We use a laryngeal mask airway, and we do that mainly because it's easy to insert, and also you get visualization of the vocal cords that sometimes is useful. But mainly because it allows us better access to the upper paratracheal nodal stations. When you have an endotracheal tube in, it can be very difficult to biopsy the level 2 regions. And so usually I will do a screening bronchoscopy first, suction out any secretions. It's a very small fiber optic on the bottom of that scope, and it can easily get covered with bronchial secretions, so sort of a toilet bronchoscopy first is helpful. When I'm teaching residents to do this, I tell them the easiest way to go in first and to get an orientation of the anatomy is to go into the right mainstem and then flex anteriorly, and you're going to start seeing the pulmonary artery, the right main pulmonary artery coming across the right mainstem bronchus, which is sort of shown here. Now, when we do the EBUS, the image is sort of flipped. But here is the right main pulmonary artery. And then by rotating the scope 90 degrees, as you know, you're going to start hitting the subcarinal region. This is a very small little subcarinal node right here. This was the esophagus that we were looking at over here. Then typically measure this in short axis dimension. This was pretty small, about 5 millimeters or so. And then we biopsy. And so it's important when we pass this, this flexible needle that you have the scope in a neutral position. That needle, although it's flexible, can damage the inside rubber-coated biopsy channel of the bronchoscope if you flex while you're passing that needle in place. I usually will pull the stylet back a little bit just to sharpen the needle, and then I'll go and I'll locate the lymph node that I want to biopsy. So once I've located where the node is, then I will undo the screw that will allow me to advance the sheath out of the end of the bronchoscope. And sometimes you can see this here on your picture-in-picture display. Oftentimes you can't. If you can't see it, then what you can do is you can push it down. You're going to be able to see deflection of the ultrasound image in the top right-hand corner of it, and that means that you're pushing on the corner on the tracheobronchial wall. Your sheath's outside, and it's safe to deploy the needle. So here we are attaching a little suction. Here's the image of the needle going through into the lymph node. There's a little stylet that we wiggle around a little bit just to get any captured bronchial epithelial cells out of the channel of the needle. And then I typically will apply a little bit of a low amount of suction, maybe about -2 centimeters of suction or so. And then we want to move that needle from really across the node, from the one cortex to another, because it's those subcortical areas where lymphatic metastases tend to go first. It's important also to keep an eye on what you're suctioning out, because once you start seeing blood, as you will here in a second, it's a good time to stop. You really don't want to have blood in your aspirate because it just dilutes out the specimens. So once that's done, then you give your needle to your assistant and go make your slides. And it's really the making of the slides is almost more difficult, I think, than the actual performance of the procedure itself. So here we place a little dot of specimen on the glass slide. You really need at least 2 people, I find, to help you with this. And then we send it off. So we can go on to the next slide now, please. So I want to go briefly over some of the original studies that show the accuracy of this technique next. There were 2 main groups, one in Chiba in Japan and one in Heidelberg. Yasufuku at that time was not in Toronto but in Chiba, and published this in 2006. And you can see here this is about 100 patients who had proven or suspected lung cancer. CT scan had false negative rate of 6 patients. There were 5 false negatives in PET, but only 2 in the EBUS F and A group. Next. And EBUS FNA was shown to have a significantly higher sensitivity and accuracy than either of these two techniques alone. Next. At the same time, the Heidelberg group published their experience with over 500 patients. For the first 50% of patients or so, they were doing this under attended local, and then subsequently switched to general anesthesia, which is, I think, what most people in the US now use. Next. But they had good diagnostic accuracy of about 94%. You'll notice that in these early studies, the median lymph node size was pretty large. These were not small sub-centimeter nodes that we were dealing with. Next. And this is a more current series. This is a registry study from Britain and the Netherlands that looked at 100 patients who underwent EBUS for suspected lung cancer. It's good sensitivity, but in this series, the negative predictive value was actually low. The reason I show this is that contralateral nodes were only biopsied in only 20% of cases. So I think you can argue that for a staging procedure, this may not be adequate. Next, please. There have been two systematic reviews. Next. The first one showed a pool sensitivity of about 88%. Next. And the other one had a pool sensitivity of about 93%. So it is an accurate technique for diagnosing N2 disease. Next. But what do we do about patients who have a normal mediastinum? Next. So there have been two studies, again, from the Heidelberg group. The first one looked at about 100 patients or so who had a CT negative mediastinal nodes and lung cancer. These patients then underwent an EBUS. Next. And in this population of patients, EBUS upstaged by 16%. So they were, 19%, but there were actually 16 patients who were upstaged to either N2 or N3 disease. Next. Now, of course, most people get PET scans, so they repeated this study, now looking at patients who had negative CT scans and negative PET scans for mediastinal nodes. And again, EBUS was found to upstage patients in a significant number, about 6%, which is about what we'd expect if we did mediastinoscopy on this same group of patients. Next, please. How about restaging? Oftentimes we'll diagnose 3A disease with an EBUS. Is it any good for restaging? One study has looked at this. Next. Again, from the Heidelberg group, they took 124 patients. They gave them all induction chemotherapy, then subsequently performed EBUS on all of them. Those that were EBUS negative then underwent thoracotomy and mediastinal lymph node dissection. EBUS was quite good at picking up persistent disease. In fact, in 89 patients, they showed that residual disease in the nodes. And the remaining 35 patients subsequently went off to thoracotomy. But 80% of these were actually falsely negative by EBUS. And so the negative predictive value in the restaging setting is very low, only 20%. Next. How about compared to his bigger and older brother, EUS, esophageal ultrasound? Next. There are two trials that I think show that combined EUS and EBUS staging is more effective than either modality alone. A small study, again, out of Europe, looked at patients who underwent both EUS and EBUS. They served as their own controls. EBUS identified malignancy in 11 patients that EUS had deemed negative. Conversely, EUS identified malignancy in 12 patients that EBUS had deemed negative. Next. So in terms of accuracy, more or less the same, but when you put them both together, certainly improved accuracy. Next, please. And then another study out of Mayo Clinic in Jacksonville, which is a really well-performed study, and no wonder it got published in JAMA. And they compared transbronchial needle biopsy, endobronchial EBUS FNA, and EUS FNA. Again, patients served as their own controls, but the important thing about this study is that the people who were performing these procedures were blinded as to the results of the previous procedures. Next, please. TBNA, blind TBNA without ultrasound guidance, had the lowest sensitivity and lowest negative predictive value. EUS and FNA and EBUS FNA were about the same in terms of sensitivity and negative predictive value, but when you put the two together, there was an improvement. Next, please. So how about mediastinoscopy? Is it going to put us out of business in that regard? I think it probably will. So I think that I'm very glad to see that 50% of people here are actually doing EBUS. Next, please. There are three studies that are worth noting. Matt DeCamp and Armin Ernst from Beth Israel performed a study including about 60 patients and showed that the diagnostic yield in terms of diagnostic specimens was higher in patients who underwent EBUS than it was in patients who underwent mediastinoscopy. And when they looked at this in a per nodal station basis, the difference was really around the subcarinal lymph node. EBUS was also had a much higher diagnostic yield with respect to malignancy than did mediastinoscopy. Next, please. However, on a per patient basis, there was no actual difference, statistical difference, in the accuracy of correct nodal staging. Next. This is a randomized study recently published out of the Netherlands where they looked at about 200 patients who had cancers that had a high pretest probability of having mediastinal nodes. They were randomized to either undergo mediastinoscopy or endoscopic ultrasound and EBUS, followed by mediastinoscopy if the ultrasound test was negative. Next, please. So they randomized to two groups, mediastinoscopy and EBUS, EUS. Of these, mediastinoscopy identified 35% of patients who had N2 or N3 disease. These were then taken out and did not receive surgery. EUS, EBUS identified 46% of patients. Next, please. So of the patients who were N0 by mediastinoscopy, these underwent surgery, and 10 patients were found to have occult metastatic disease in the N2 or N3 nodes. In the group of patients who were EUS negative, these patients underwent mediastinoscopy. A further 6 patients were found to have occult mediastinal nodes. The remainder underwent thoracotomy. So basically, false negative rate for mediastinoscopy was 9%. False negative rate for endoscopic ultrasound and EBUS staging was 8%. Next. These are the sensitivities, and you can see that the combined procedure using EUS, EBUS, and mediastinoscopy had the highest sensitivity and accuracy. Next, please. And then lastly, this is a study out of Toronto by Kazu Yasufuku and his group there. 153 patients all underwent EBUS TBNA followed by mediastinoscopy. Those that were node negative underwent thoracotomy. They were not biopsying particularly large nodes. In fact, the average diameter, I think, of the nodes was about 8 millimeters. They used rapid on-site evaluation as well. Next, please. So both procedures had low complications. There was one patient who had a recurrent laryngeal nerve palsy in the mediastinoscopy group. No complications reported by EBUS. Next. And contrary to the RINTOOL study, the registry study that I showed earlier, where N3 nodes were not being biopsied, this group did a really good job of biopsying both ipsilateral and contralateral, as well as subcarinal nodes in pretty much everybody. Next, please. But there was no difference in the sensitivity, negative predictive value, or the accuracy of EBUS versus mediastinoscopy in this group of patients. More nodal tissue was obtained by mediastinoscopy, and there were a higher number of nodes per patient biopsy by mediastinoscopy, but this did not translate into improved staging accuracy. Next, please. So in the last couple of minutes, I just want to touch on something, the decision as to whether or not to perform this in the operating room or the bronchoscopy suite. Traditionally, when we started doing this at Anderson, we certainly did this most of the time in the operating room. Next, please. So we went back and actually looked at our data over about a 3.5-year period, and during that time, we did EBUS just as a standalone procedure. So this was not EBUS followed by some other, lobectomy or something. This was just EBUS on its own. We did 114 patients in the operating room and 20 patients in the bronch suite. All of these were performed by surgeons. Next, please. And what we found was that the actual costs were significantly higher, not surprisingly, in the operating room than in the bronchoscopy suite, but payments were a little bit higher in the bronchoscopy suite. Next. And if we look at where those differences lie, it's mainly in terms of the technical charges. Next. Versus the professional charges. Next. And if we look at our absolute margin on a per patient basis, we made about a little over $1,000 for patients that we did this procedure in the bronchoscopy suite, but conversely, we lost about $1,000 if we did it in the operating room. So this has really changed where we aim to do most of these procedures. We will still do them in the operating room if they are linked to another procedure, but otherwise not. Next, please. Our payer mix was about 50-50 Medicare or Medicaid versus HMO or private. Next. In terms of professional reimbursement, we found that private payers reimbursed well. Medicare, you got about $250 for the procedure. Next. Our overall margin was excellent. If Medicare were not paying for it, it was about negative $4,000 per patient if Medicare paid. Next, please. And unfortunately, if we took all these 134 patients together, we actually came out negative to a tune of over $100,000 for these patients. Now, I think this would change now because I think we would do these patients now in the bronchoscopy suite. But you know, this changed our practice, and I'm sure it's going to be different at your hospitals because your payer mix is going to be different, and costs are probably a lot different as well. So next, please. So in conclusion, I'll finish up by saying that I think EBUS is a very, very useful, minimally invasive tool for staging the mediastinum. Next, I think it is going to be shown to be as accurate as mediastinoscopy, and I think for routine mediastinal staging, it is going to change what we do. The negative predictive value is poor, I think, for restaging, but you know, if you're not going to operate on a patient who's not been downstaged, then the sensitivity is in the mid-70s, so it may be worthwhile doing it. But a negative result doesn't necessarily mean that that you've sterilized the mediastinum. I think the way things are going, the combined procedure with EUS and EBUS is going to be the most accurate way that we have of minimally invasively staging the mediastinum. Next, please. And at least at Anderson, these procedures, where possible, should not be done in the operating room, but in the bronchoscopy suite. So thank you for your attention.